and thank you for joining us today for the Improving Outcomes for Pediatric, Adolescent, and Young Adult Cancer Survivors pre-application webinar. My name is Jennifer, and I will be your WebEx host for today. Before we move on into introducing our speaker for today, I'd like to cover a few housekeeping details. All attendees have been muted upon entry and will remain muted for the duration of the webinar. Please submit your questions throughout the presentation in the Q&A or chat panel and select all panelists from the drop-down. We will ask them on your behalf during the Q&A portion of the webinar. Questions about specific aims will not be addressed during the webinar, and you can reach out to those individuals specifically regarding specific details to your application. If you need to view live closed captioning, please refer to the media viewer panel. This webinar is being recorded and will be posted online Sorry about that. And we will also have a feedback survey. Please take a moment to complete that at the end of today's webinar. And now I'd like to turn it over to Dr. Sandra Mitchell to begin the presentation.
Great. Thank you, Jennifer, and welcome, everyone. We're very pleased to be here today to present and hopefully address questions that you have about this RFA. We're quite excited about it and look forward to sharing some information with you. So just in terms of where topics we'll address today, we're going to look at the background and scope of the problem. I'll address the goals of this request for applications, talk about some of the application requirements, and then we will also address some of the questions that were sent in advance, and to the extent that we have time, the additional questions that you all will be posing today. And my colleague Danielle Day will be moderating that component of the presentation. Please note, as Jennifer indicated, that questions about specific aims and specific grant application details will not be addressed, and you can reach out to Danielle and I as the scientific contacts for this RFA to discuss those more specific and particular questions. So first, I'm just going to give a little bit of a very brief background on this RFA, and I think as probably everyone on the call knows, long-term and late effects following cancer treatment for pediatric and AYA survivors are prominent. They have significantly more chronic health conditions compared to controls, and as this slide illustrates, the cumulative burden increases as the survivor ages. These complications include a wide range of organ system complications and comorbid conditions. So this RFA and today's discussion will focus on the survivorship research provisions, and NCI, through its Office of Cancer Survivorship, is issuing this call for applications both to build on the Institute's ongoing commitment to advancing childhood, adolescent, and young adult cancer survivorship, and to foster research applications that align directly with the areas emphasized in Section 202 of the STAR Act. And you can see here that this RFA is specifically designed to address research to improve the care of and quality of life for survivors. So 6 key research areas to improve care and quality of life for childhood and AYA cancer survivors were highlighted in the STAR Act, and you can see those here on this slide. They include improving survivor outcomes, addressing barriers to follow-up, considering the impact of familial, socioeconomic, and environmental factors on treatment outcomes and survivorship, the development of indicators for long-term follow-up and the analysis of late effects, identification of risk factors, predictors, and molecular bases of adverse events, and then what we're going to be talking about today, the development of targeted interventions to reduce the burden of morbidity in survivors. And the STAR Act also highlighted that health disparities, minorities, and other medically underserved populations are of particularly high priority. This work is also a component of the Beau Biden Cancer Moonshot Initiative, and probably most people on the call are familiar with that initiative. But if you're not, we've indicated the goal here, which was to accelerate progress in preventing, diagnosing, and treating cancer by accomplishing a decade's worth of work in 5 years. And the Cancer Moonshot received $1.8 billion in funding to be distributed over the next 7 years. And this RFA accords with the recommendations to minimize cancer treatment's debilitating side effects And in particular, we are focused here on accelerating the development of effective interventions to evaluate and manage symptoms and side effects. So in terms of the goal of the RFA, the goal is really to support the scientific development of interventions to address adverse biomedical and psychosocial effects in survivors of pediatric and AYA cancers. And with this RFA, we are leveraging insights from observational studies, and you can see several of those highlighted here that we think are particularly important in terms of motivating the development of interventions. We've divided these into interventions to improve cancer care delivery and interventions to directly address adverse effects. So we know from observational studies that as survivors transition out of pediatric settings, only a minority are seen by a provider familiar with late effects. Those same survivors express unmet needs for organized long-term follow-up services, and we know they're at increased risk for physical, psychosocial, and behavioral adverse effects, as well as experiencing accelerated aging and physiologic frailty. We've also indicated here the range of adverse effects that these survivors experience. They can include physical symptoms, physical functioning impairment, neurocognitive impairments, and a variety of late treatment effects, as well as psychosocial concerns like psychological distress and disrupted social development, as well as behavioral concerns such as reduced physical activity and the potential to engage in risky behaviors. So in terms of the aims that should be pursued for this RFA, the goal is really to develop feasible, effective, and scalable interventions to address biomedical and psychosocial effects in survivors of pediatric and AYA cancers. And we see the aims focusing in one of two areas. First area is testing interventions to prevent, mitigate, and manage adverse long-term disease and treatment-related effects. And this will include interventions to promote self-management and adoption of healthy behavior. The other focus for intervention is developing and testing models of healthcare delivery that strengthen coordination, continuity, and quality, and also improve outcomes. So aims submitted under this RFA must employ a clinical trial study design. In terms of just elaborating a little bit more on the kinds of trial designs that we envision, because this is development and testing of interventions, those trial designs may include early phase studies to develop and preliminarily test a novel intervention. They may include phase 2 or phase 3 studies that are testing efficacy. It may employ a pragmatic trial design to confirm intervention effectiveness in a real-world setting. And it may also be a dissemination and implementation study, including hybrid effectiveness implementation designs that examine scale and spread of empirically supported interventions in diverse usual care and real-world kinds of settings. Considering the populations that are the focus for this RFA, the population focus is on pediatric and/or AYA cancer survivors who were diagnosed before age 39. The population of interest is those pediatric and AYA survivors who are at risk for or experiencing long-term and late adverse physical, psychosocial, and/or behavioral outcomes in the post-treatment period. Population focus for this RFA also includes their caregivers, parents, and/or spouses. As said earlier, we will be prioritizing applications that address health disparities, minorities, and/or medically underserved populations. And it's worth pointing out that interventions may be targeted at the individual provider or system level and may include multi-level interventions. There are a number of considerations that we'd like to highlight around the approach to be taken to addressing these aims. And I think a couple of these are very important to underscore. It is absolutely critical that applications address access barriers that include geographic distance, literacy, functional deficits, and preferences to engage. And not all of these access barriers have to be addressed simultaneously, but there needs to be vigorous consideration of the known access barriers to service access for this patient population. It's also going to be critical to examine meaningful proximal endpoints. Certainly some of the endpoints that are relevant for testing survivorship interventions are much more distal, but we want applications to have meaningful proximal endpoints so that we will know at the end of the funding period which interventions worked and for whom, and to address which endpoints. Some applications may propose mechanistic study aims, for example, how and why an intervention works, and that is certainly within scope and encouraged, but it will also be important to address the pragmatic implications of that explanatory knowledge. For example, can that knowledge about how and why an intervention works, can it be used to amplify intervention effects or optimize an intervention? We want to encourage applications that leverage advances in digital and mobile health solutions because we believe that these kinds of solutions will actually help to address some of the access barriers noted above in bullet 1, and also are coherent with what are the known preferences for adolescent and AYA survivors to engage. And it probably goes without saying, but we just want to point out that interventions tested for effectiveness and or in implementation pragmatic trials should have demonstrated feasibility and efficacy. So let's just consider a few of the potential research topics, and these are just some examples of some selected topics. It's by no means a comprehensive listing. But you can see here in terms of interventions to prevent and mitigate adverse outcomes, examples of this include interventions that improve access and decision-making about the use of fertility services, interventions to prevent or mitigate late effects like secondary malignancies, or to prevent and mitigate persistent or long-term effects like fatigue, cognitive dysfunction, frailty, functional impairment. Interventions are also needed to mitigate adverse outcomes in specific subgroups who are at highest risk or who are most likely to derive greatest benefit from early intervention. Interventions are also needed to expand the reach, adoption, effectiveness, and maintenance of healthy lifestyle changes. And interventions need to be tested and developed to support caregivers, parents, and spouses, help them mitigate the adverse sequelae of their own caregiving role and or improve survivor outcomes. Thinking about priorities in the areas of healthcare delivery, a few ideas that we think represent key priorities. The first one is just to comparatively evaluate components, features, cost, and value of care models that optimize the key transitions in care. For example, the transition from pediatric to an adult setting, the transition from specialty to primary care, or transitions that need to happen for this very mobile developmental group based on their geographic relocation. Another important priority in healthcare delivery is to identify care delivery approaches that strengthen self-management, improve clinical outcomes and access, and achieve guideline concordant care. Also important is to evaluate the outcomes of risk-based healthcare delivery targeted to specific subgroups who warrant more intensive intervention and follow-up. And critical is testing novel approaches to care coordination and communication. Care coordination and communication is an important gap identified by these pediatric and AYA survivors themselves, and outcomes of some of these novel approaches include cost, quality, and experiences of care, among other relevant endpoints. Now, based on the questions that have come in, a number of people have noted that these are U01 awards, and we want to just highlight that each U01 award will be based on an independent project, but also that awardees will engage in trans-network interactions and participate in an annual investigator meeting, and budgets that are being submitted should reflect inclusion of these activities. NCI staff role will include scientific support and assisting with coordination of interactions among grantees, as well as facilitating collaboration and information sharing. Now, as might be assumed from some of these remarks, there are a number of types of applications that would be non-responsive to this RFA. It's important to note that applications must propose development and testing of interventions to address physical, psychosocial, or behavioral adverse effects in pediatric and or AYA survivors, and as such, descriptive and observational studies are not responsive to this RFA. Also not responsive would be applications that propose testing of interventions that address short-term or transient adverse effects of treatment, as well as applications that propose development or testing of cancer-directed therapies. Those would also be non-responsive. I want to just highlight a few details of the application requirements, but would refer people obviously to the RFA, where much more detail on this and some other resources and links that you can pursue are provided. So just to highlight a few salient features, we have 2 receipt dates. The first one is fast approaching in March. There's been a very rapid turnaround for this RFA, and we're very excited by the response as evidenced by the participants on today's webinar. So March 15th is the first receipt date, and the second one is January 3rd, 2020. We will be convening a special emphasis panel for review, and it's important to note and address the special review criteria that are highlighted in the RFA, but I just bring these to your attention here. It's important that the application explicitly address the significance of the proposed intervention in addressing a priority need or knowledge gap for pediatric and AYA survivors, and it's also essential that there be relevant and meaningful proximal endpoints. We're requesting the letter of intent be submitted, and for this first receipt date, that letter of intent is due to Dr. Daniel Day by February 15th. Also want to just highlight, because these are all clinical trials, that there are a number of application requirements specific to an application that includes a clinical trial, and as probably most people are aware, NIH requirements for clinical trials applications were updated in January 2018. And it's very important to be sure to learn about and understand several of the policies. I've highlighted them here. I think what's critical is that the application form now consolidates all human subjects and clinical trial-related information into one place, and does expand the information required for applications that include a clinical trial. It's also important that investigators and staff receive training in good clinical practices, that sites that are proposing a multi-site study plan to use a single IRB, and all NIH-funded clinical trials are expected to register and submit results to clinicaltrials.gov. And you can learn more about the clinical trials requirements at the website here. In terms of highlighting some things about budget, the budget should obviously reflect the actual needs of the proposed project. However, the budgets may not exceed $500K in direct costs per year. And it's important to note that R01 modular budgets are permitted here. So just to summarize, it's critical that the aims in applications submitted in response to this RFA reflect the testing of interventions to prevent, mitigate, and manage adverse long-term disease and treatment-related effects, or that the aim reflects development and testing of models of healthcare delivery that strengthen coordination, continuity, and quality. The aims must reflect a clinical trial study design, and note the NIH requirements for clinical trials applications. In terms of the target populations, pediatric and or AYA cancer survivors who are at risk for or experiencing these long-term and late effects are the focus here. The focus is, though, in the post-treatment period. There's also, within scope, a focus on their caregivers, parents, and spouses. And note that interventions may be targeted at the individual provider or system level and may include multi-level interventions that target several of these levels. In terms of the approach should reflect, as we've said, consideration of these access barriers, literacy, functional deficits, and preferences. The approach must include meaningful proximal endpoints. Mechanistic study aims have to also address the pragmatic implications of that explanatory knowledge. In other words, how can it be used to actually amplify intervention effects, optimize the dose of an intervention, or optimize the components. We very much want to encourage applications that leverage advances in digital and mobile health solutions so that these studies will be in line with where contemporary practice is moving, and interventions tested for effectiveness and implementation in pragmatic trials must have demonstrated feasibility and efficacy. The budget may not exceed $500,000 per year in direct costs, and modular budgets are permitted. Before we turn our attention to some of the questions that are coming in, I want to just highlight some of the resources here. First, be sure to read the FOA very carefully. There's a lot of detailed information. We've tried to highlight that here, but there is a lot of detailed information to help guide you. We also want to be sure that you know the access and data sharing plans required by projects funded as part of the Cancer Moonshot, and more information about that can be found at this link. As Jennifer said earlier, today's webinar and FAQs will be posted within about a week or so, possibly sooner, to our website, and you can see that here. And we do encourage you, if you have questions about your specific application or about topics that we haven't addressed today or won't be addressing through the questions, that you are in touch with us to talk about those, and we've indicated the scientific contacts. So I think with that, I'll turn it over to Dr. Danielle Day, who will moderate our Q&A section, and I think we've got questions already coming in.
Yeah, questions are already rolling in. Thank you, Sandy. So the first question, how do you define a survivor?
So it's a very good question. We are basing this on the definition of a cancer survivor as defined by the NCI Office of Cancer Survivorship, and that definition encompasses individuals who are considered cancer survivors from the time of diagnosis through the balance of his or her life. And we, with this definition, recognize that there are many types of survivors, both survivors living with cancer and those who are free of cancer. This RFA is specifically requesting intervention development to improve care delivery for this population, and interventions may be targeted to the survivor, to the caregiver, or to the providers.
Okay, great, thank you. So can you speak to how important it is to submit to the first deadline of this FOA versus the second, which is later in 2019, or in 2020, actually?
So I think there are a number of considerations that investigators will need to think through explicitly for themselves and within their teams in thinking about whether to get something in by this early March date or to incubate things further towards that January 3rd, 2020 submission date. It's, I think, perhaps important to those deliberations. It's important to know that resubmissions will be allowed even for the second submission date, and that in those resubmitted applications, applicants can specifically address reviewer comments from the first submission. So I think there are probably, on balance, a number of advantages to submitting for that early receipt date, but we obviously understand that there are other things that investigator teams are going to have to balance in making that decision for themselves.
Can you explain whether interventions can be proposed that are done site by site and then compared to each other to determine the optimal intervention?
So I think that is an interesting study design. My response to that is that I would be very careful to cast that approach within a one of the well-defined study designs for testing interventions. So, for example, and some of this, this may be a question that is going to be, I think, perhaps too particular to what the intervention actually is. But I guess as I'm hearing that question, I'm imagining that you might have 3 sites and that each site is testing a slightly different, perhaps, dose, perhaps testing a different mechanism for delivery of the intervention, for example, a digital remote intervention versus a face-to-face intervention, for example. And then, so it would be almost like you're having sort of a three-arm trial. I think you'd have to, in that design, consider what really is the comparison group, and that's why I would be very careful to cast that within, for example, if that's going to be a phase 3, three-arm study, thinking about what is really the control of the comparison group, and then how it's be compared to determine which interventions are optimal, I think is what it said. Mm-hmm. So how would you actually be deciding what is the optimal intervention in that case? Is it effectiveness? Is it cost? Is it acceptability to different patient populations? So I think that kind of design potentially could be responsive, but the devil is going to be in the details in terms of how the design is kind of crafted, what the endpoints are, what the comparison group is, and how the interventions differ by site. The other piece that needs to be considered, and that's a highly technical component, is that the modeling of that will need to reflect the fact that the intervention is nested within a site. And so that is going to require that you introduce some controls for the natural clustering of outcomes that will be based on site rather than on intervention. So power considerations there will also be an important factor to address in an application that would use that kind of design.
Thanks, Sandy. Will you accept international collaborators on applications?
Yes, great question. International institutions and collaborators are definitely eligible to apply, and non-domestic entities and foreign institutions are also eligible to apply, and foreign components as defined in the NIH grants policy statement are allowed, and in the FAQs we'll give you a little website for some more information about those.
Okay. Does early stage investigator or new investigator status apply to these RFAs?
Yes, early stage and new investigator statuses do apply, and in grant applications that involve more than one PI, in other words, a multi-PI application, all PDs and PIs, however, must meet the definition of a new investigator or early stage investigator for the application to be designated as such. So we certainly, as has been articulated by Dr. Sharpless in many different forums, NCI is very committed to supporting early stage investigators and will place special emphasis on supporting early stage investigator designated applications. However, it is important to note that in a multiple PI application, in order to qualify for that, both or all of the PIs in that multi-PI application must meet that new investigator or early stage investigator designation.
Do you have any tips for young investigators to, as they prepare their applications?
So I think certainly we can imagine that there will be some early stage investigators who wonder, will they be seen as prepared, as it were, to really lead a U01 application. And again, I think that there probably are no generalities that we can state there. Like any application, I think it's important to put together a strong team and to be sure that if the investigator is a very early career investigator, that they have included senior investigators on their team, and that the effort applied by those senior investigators is commensurate with the contributions that are thought to be needed in order for that to be a successful project. But certainly, as I said earlier, NCI is very committed to supporting early stage investigators, and we will certainly place special emphasis on supporting those ESI applications that do score well.
Okay, great. Is an ARA required for budgets that exceed 500K direct costs?
So just that's a great clarifying question. As noted in the slides and also in the RFA, application budgets for this may not exceed 500,000 in direct costs per year, and thus the ARA policy does not apply.
Okay, great. Just a moment while I read through some of these. So why are we using the U01 mechanism versus an R01?
So the U01 mechanism was the recommendation to us from senior program leadership at NCI and from many of the leaders and experts in pediatric and AYA cancers here at NCI, as well as it was a feature that was strongly praised by the NCI Board of Scientific Advisors. The U01 mechanism allows for NCI to provide scientific support and program coordination amongst awardees, and we felt that particularly for this area of developing interventions, it will be important to have collaboration and information sharing across individual awards, both to strengthen the science that is being done, but also to hopefully plan for implementation and translation into practice of these developed interventions.
Okay, great, thank you. So will all types of trials be equally preferable? So for example, a feasibility trial versus a phase 3 trial versus an implementation trial?
So that's a great question, and I think what is an important touchstone is thinking about the special review criteria that we highlight, and I'm just going to go back to those. Because I think what is absolutely critical is that the intervention proposed for testing address a priority need and or knowledge gap for pediatric and AYA cancer survivors. And when you think about really the paucity of known effective interventions to treat these long-term and late effects in pediatric and AYA survivors, these gaps are very prominent. So this is a wide gap to be filled. It can be filled with feasibility and preliminary efficacy trials. It certainly can also be filled by a phase 3 trial that's really confirming efficacy in a large randomized sample. There may also be some interventions for pediatric and AYA survivors that are ready for implementation trials. So I think what is important here is to think about the gap, think about what your research teams are poised to do, and then consider where is the state of the science. Feasibility studies should probably include a focus on at least some preliminary testing of efficacy signals, or at least on the endpoints so that you actually know the effect size to power, let's say, a larger trial. So I don't know that something that's only a feasibility trial and only addressing feasibility in a limited sense would be as strong as, let's say, a feasibility trial that also included some preliminary efficacy endpoints and also was well poised to determine acceptability for the population and also effect sizes so that you can power a larger, more definitive trial.
Okay, great. So going back to the question about the 2 submission dates, so a question came in about resubmissions after that second date. So if you apply with your initial application on that second date, will there be an opportunity to reapply?
Unfortunately, if you submit to that second date, there will not be an opportunity to resubmit under the RFA. A new application certainly could be submitted into the, under the general R01 program announcement. There may be other program announcements that emerge between now and the time of that 2020, post that 2020 deadline. But unfortunately, if you do resubmit, or if you do submit to the general R01, you're not going to be able to directly address reviewer concerns in your cover letter. So apropos of the earlier question about kind of strengths and weaknesses of submitting for the first date versus the second date, that kind of highlights another potential, strength and weakness to be factored in.
Great, thank you. So another question from the webinar, would a trial to use a pharmacologic intervention during cancer treatment to prevent or mitigate later effects be considered as responsive?
So yes, this would be considered responsive. I think that the devil would be there in the details about whether that pharmacologic intervention given during cancer treatment, it could be pharmacologic or behavioral intervention given during cancer treatment, it would be important to establish that it does actually prevent or mitigate whatever that late or long-term effect is. So there would need to be preliminary data that clearly indicates that that intervention, when delivered during treatment, does mitigate a late or long-term effect. But it certainly would be responsive.
Okay, great. Are studies with a behavioral endpoint as a primary outcome of interest allowed?
Yes, those studies are certainly responsive, but again, I think it would be important that you're trying to test intervention efficacy, and so whatever those endpoints are going to be, they need to be cast in a way that you can actually determine that the intervention was effective. So that can be potentially a little bit challenging to do with some of the solely behavioral endpoints, but there's a balance here between having proximal endpoints and having endpoints that are responsive to the intervention itself.
Okay, there's been a question about the letter of intent. Please explain what the letter of intent should include.
We have some information in the RFA for some more specific instructions about that, and you can also be in touch with us to get some additional clarification.
Okay, great. How much preliminary data on intervention is needed prior to an application?
So that's a great question, and some of our earlier remarks have addressed this somewhat. Certainly, reviewers will be looking at the application in terms of the logic and prior data that supports the intervention, either that supports, if it's a preliminary testing of an intervention, that suggests that such an intervention is going to hit a target that is of relevance. If it is an intervention being tested, let's say in a phase 3 study, there should be some preliminary data that indicate feasibility and acceptability, preliminary data that indicate the anticipated effect size for the intervention, so that your power analysis is well rationalized, well justified. And preliminary data may also be needed if it is, as indicated earlier, you're suggesting an intervention that you're indicating is mechanistically related to a more distal late effect. You would want to have some preliminary data that, for example, indicates that that intervention does actually move the needle on that more distal late effect. The other place for preliminary data is being able to demonstrate that your team has the ability to deliver the intervention, and I think importantly that you have access to the population and the intervention acceptable to the population and feasible to do.
Okay, great. Will this RFA support prognostic biomarkers to direct interventions or predictive biomarkers to suggest drug sensitivities?
So certainly studies may include biomarkers, both prognostic and predictive, as a component of looking at proximal endpoints, or to, I think importantly, understand the mechanisms of a proposed intervention. If it's a biomarker that's being used to evaluate the proximal endpoint, again, preliminary data would have to indicate that that biomarker is responsive to it. So that is a comment with respect to biomarkers. Thanks. Just trying to see the other part of that question. Yeah, I think that's, yeah. So prognostic biomarkers to direct interventions, or predictive biomarkers to suggest drug sensitivities. Again, as long as it was a drug being tested, potentially. So a lot of these kinds of questions, the devil is really in the details about what kind of intervention we're talking about. And I think if people have questions about the inclusion of biomarkers, I think that would actually be something to talk with Danielle and I about in a short consultation, just to be sure that you know, the role of that biomarker within the intervention trial is clear and well justified, and also is proximal and also known to be responsive to the intervention.
Fantastic. So there have been a few questions about who to contact about this RFA. So I think now we're showing the slide for the letter of intent. Do you want to change it to the scientific program contacts on here, on the webinar, Sandy? I think you have a slide that shows the scientific contacts for the RFA.
Yeah, no, the scientific contacts are indicated right there.
I think that just shows me for the, yeah, there we go.
Yeah.
Perfect.
Yeah.
All right, awesome.
So you can direct questions either to Danielle or to me, Sandy Mitchell, and we will either respond by email if it's that kind of question, or reach out to set up a time. We've already been actually talking with a number of investigators who have had specific questions about their intervention development or some of the other topics we've addressed here.
Okay, great. Do you want to comment on whether there will be other RFAs coming out to address the Section 202 goals?
So that's a great question, and indeed there are some additional announcements. This RFA is, NCI sees it as a very important step in our efforts to implement sections of the Childhood Cancer STAR Act. And I think it should be noted that we're very grateful to all of our NCI colleagues, as well as to NCI leadership and the Board of Scientific Advisors who contributed to this process, because they worked very, very quickly, that our entire group and team, to develop and post this funding announcement so soon after the STAR Act was signed into law. Development of an FOA concept like this and approval by NCI leadership and advisory board's final publication typically takes more than a year, and this was actually accomplished from like August to December. So NCI is continuing to work on implementation of other sections of the STAR Act, and we can put you in touch with our colleagues in NCI's Office of Government and Congressional Relations or the Office of Advocacy Relations for some additional information about that. But I think suffice it to say that NCI is working to implement other sections of the STAR Act that were directed towards our institute.
Okay, great. So a clarifying question about the contact, the scientific contacts for this RFA, and the people are just asking who they should contact, and I think it's important to just say you can contact either of us, and then collectively together we will get back with you and consult with you as a team. Thank you. Let's see if there's more questions here. Okay, so this is a question about the targeted population. So what qualifies as research focusing on pediatric young adult survivors, and what's the upper age limit for this group of participants?
So this is not focused on adult survivors. So pediatric, the focus for this RFA is pediatric and adolescent young adult cancer survivors. I just want to clarify that. So a pediatric, as we said earlier, based on the definition utilized by the NCI Office of Cancer Survivorship, the cancer survivorship experience begins at the day of diagnosis. Pediatric and AYA cancer survivors, and I'm just going to go to the population, target population here. So pediatric and AYA cancer survivors are those who have been diagnosed with their cancer between the ages of 0 and 39 years, so younger than 39 years, and they are the focus for this RFA. So the upper age limit for the age of diagnosis is age 39, but we know that even those diagnosed at or around age 39 may be followed into later adulthood, and there is no upper age limit for their inclusion in studies of adolescent and young adult cancer survivorship interventions. And again, just to point out that for the population, it's these pediatric and AYA cancer survivors who are at risk for or experiencing long-term and late effects in the post-transplant or post-treatment period, and it would not include interventions that are designed to address short-term, acute treatment-related effects.
Okay, great. And I think we have maybe one more question here. So can you provide more detail about what is meant by health disparities being a high priority?
That's a great question. And this is an area, there's been a couple of very good recent reviews of pediatric and AYA cancer disparities, and I would encourage people to take a look at those to understand better the full scope of health disparities. But health disparities are differences, specifically differences in access or differences in outcomes that are systematically and negatively impacting less advantaged groups. Some examples of disparities are some of the obvious ones: racial and ethnic minorities, rural populations, urban poor populations, other medically underserved populations. For example, fertility services are not available in a distributed manner to all those who might need them. Similarly, access to survivorship clinics are also not available in an equally distributed manner. So there are many different types of medically underserved populations that do incorporate disparities. So the development of interventions that address or target these known health disparities and the needs and preferences of minorities and medically underserved individuals will be a very high priority in all of the research areas.
Okay, great. It doesn't look like we've had any additional questions come through. Well, perhaps one. Let's hold on for one moment, please. Oh, there it is. Okay. This is about the letter of intent. What proportion of letters of intent do you anticipate to be accepted, and I guess we should talk about how the letters of intent are used.
Yes, so it's not going to be possible for us to indicate what proportion of LOIs we anticipate accepting, because we have really no idea, whether the LOIs that come in are going to be responsive. But assuming that they would be, we will be welcoming all of the projects that are submitted by the letter through the letter of intent, as long as they are responsive to the RFA. In terms of a timeline for getting back with you, I think it will be in less than 2 weeks we will respond, and I would anticipate it would be more like a week, because we know that the timelines are very, very short between the final date for letter of intent and the date for submission. Now, we certainly encourage people, you can submit your letter of intent. You don't have to wait for February 15th for that. So we would encourage, if you already know that you want to submit to this RFA, to send along the letter of intent. And as a minimum, I would anticipate describing the areas that we highlighted, the aims, the target population, a description of the intervention, the kind of study design that you're envisioning, any of those special considerations around the approach that you're highlighting. That could be using a digital solution. It could be around a particularly medically underserved population, any of those considerations around approach. So I think you can, the letter of intent does not have to be long, but it should at least allow us to determine that it is responsive to the RFA, and that would require some detail around the aims, the patient population, and the intervention being tested and the study design.
Okay, and one more question. Can you talk more about the budget of a U01 mechanism? Maybe we can talk.
Yeah, so I think important for the budget, let's go back to that slide, that the budget does need to reflect the actual needs of the proposed project. As we said, it may not exceed $500K. It can be a modular budget, and I think the only real important consideration difference between a U01 and an R01 would be that the application budgets do need to allow for or consider the fact that there will be some in-person meeting, an annual in-person meeting. We anticipate it will be annual, and that there will be some other interactions among grantees that would probably be done by video conferencing and those kinds of things. So there, it wouldn't be travel, but it will certainly be some percent effort, either from project coordinators kind of pulling together members of your team to participate in that, and some participation and leadership from the PI or multi-PIs around their participation in those. So I think there's nothing else that's unique about the U01 budget, but the allowing for percent effort and travel, as well as any other infrastructure costs that you might have, for example, to participate in video conferencing and bridge services, those kinds of things. Most places have that already as part of their infrastructure, so I don't really see that necessarily as being a cost, but there may be some costs there if you anticipate, for example, involving other sites, because your design involves, lots of populations that are, and maybe clinical settings that are not well resourced. There may be some needs there. So we're glad to discuss that in more detail if there's a specific question about whether something should be incorporated in the budget, but in general, the only difference would be that the budget should reflect travel and staff involvement in these coordination activities.
Okay, fantastic. I think that's all the questions that we have. I will note that we will post an FAQ document along with the webinar recording, so you will have that resource available as soon as in a couple of weeks or so.
Perfect. Thank you, everyone, for all the questions you sent in. It seems like we had a lot come in from the webinar, and then also some that were submitted during the registration process. Thank you so much for your time, and also thank you to Sandy and Danielle for a great presentation. And with that, all the resources will be posted in the next week or so. Thank you.
Thanks, everybody. Best wishes.